Today I'll be doing the history and observation part of a hip evaluation. So you ask your patient about any injuries that they've had to the hip or the lower leg, and you also ask about any past medical history. And you ask the patient if they have a mechanism of injury, and if you saw it, then you already know what happened, but just to get their side of the story. And they have, and their pain level right now. And then you ask about any popping, clicking, or locking sensation. And then for observation, you look at muscle tone and compare it bilaterally from the injured side to the non-injured side. You focus mainly on the adductors, the glutes, quads, and the hamstring. And then you also look for any deformities, obvious deformities, any redness, swelling, discoloration. You also look at the iliac crest to see if there's any contusions or bruising, and then you also look at the IT band, all for the observation and history.
So for this section, I'm going to be doing the palpation portion of a hip evaluation. So first we're going to start off up top at the ASIS, so the pointy part of the hip. And then you want to go down to the AIIS, which is the anterior inferior iliac spine. ASIS is anterior superior iliac spine. So you want to palpate the sacral crest as well, median sacral crest, greater trochanter on the side. A good way to palpate this is ask them to poke their hip toward you. And then you feel for the bony part of the femur, so in which this case hers is right there, which also while you're here you can palpate IT band all the way down, and you can also palpate the TFL. So those two go together. We can do the rectus femoris, which inserts at the hip and at the knee, so it's a two jointed muscle, runs right along here. Sartorius, so from the ASIS, crosses the thigh and then inserts at the pes anserine. Alright, and then at this point we can get them to flip over. Good. So you can do the adductors gracilis. You can palpate those either supine or prone, in which case it is on the the medial aspect of the thigh. And we want to palpate the glutes. So we have glute med and glute min that we can palpate. So ask the patient to poke out their hip again. Thank you, relax. And you can palpate glute med and glute min at this point as they connect to the greater trochanter, as I was describing before. Excuse me. So now we can do the ischial tube. So in the case of patient contact, I'm working with a female. I ask for permission. I have someone watching me to vouch for me. So I'm gonna say I need to touch your bottom. So is that okay?
Yes.
So you look for the gluteal fold. Make sure that your hand is up. You don't want to get any grabbing motion in. So up. You push up on the bony prominence that is the ischial tube. And at that point, the sciatic nerve, ischial tube, greater trochanter runs about halfway. So you ask for permission again. And PSIS, which is up here, which are back dimples. Hers are kind of hard to spot. There we go, right there. And then lastly, one of the biggest muscles, you have the hamstring. So you have the biceps femoris, which are on the lateral side. And you have the semis, so the semi-tendinosus membranosus on the inside. And that is the palpation section for a hip evaluation.
The special test portion for the hip evaluation, the first test is the fulcrum test, and so for this, I'm putting my hand under her hip, under the back of her knee like this. I'm pushing down, and if she's having pain, it would be up where the femoral head would be, and that would indicate a femoral head fracture. You can lay down for the next one. And then just a squeeze test of the femur to indicate a femoral fracture. And then you can also do the bump test and see if there's any pain running up the leg. You also have hip scouring. So you have the patient in a 90-90 and you're compressing down and rotating, and you're seeing if there's any catching, apprehension, pain with this, and that could indicate a labral tear. of the hip. Next, we could do range of motion. So range of motion of the hip is flexion, extension, abduction, adduction. So with abduction and adduction, you can have them actively bring their legs out. So like that, see how far they can go, and then come back in and cross your legs for adduction. And then flexion of the hip, just bring it up to the sky, like that, as far as you can go. And then extension, flip over. And then bring your leg up, whichever leg up, and try to have their body, hips not rotate off the ground. And then you can do that for passive and resistive range of motion. Can you turn back over? You also can measure the Q angle of the leg, of the hip. So that would be having the fulcrum at the patella, the stationary line in line with the femur, and then the movable arm with the tibia. And so you would indicate the number where it's at. So that's about 12 degrees. It's between 10 and 12 for males, and then 12 to 15, not exceeding 15 in females. Over 15 would be abnormal and could indicate other injuries. And then manual muscle tests. So can you sit up for me? First we have the hip flexors or the iliopsoas. So you bring your knee up to the ceiling, hold this position, push down, and do it bilaterally. You also have the hamstrings. Oh wait, sorry, hold on. Do the internal and external rotators first. So you have the internal rotators, you have them out like that, and you push them in, so hold this. You do that bilaterally, and then the external, and then push them out. Also do that, check that bilaterally. Now you can lay on your side. Next we have the hip extenders, so the glute max. So you would bend their leg and put your heel up to the ceiling, push up, and I'm going to be pushing down in their leg like this. Okay? And then flip onto your back. Or sorry, your side first. And then next we have glute med. So it goes glute med first. So this one is just having their leg out like this, and you're pushing down like that, and then rotate, or we can do the adductors next. So put this leg down and bring this leg up like that, and the adductors push down, compare bilaterally, and then flip over. Yeah. And then the last is sorry, flip on your side. And then this one is glute medius, so you rotate out like this and hold it, and you're pushing down. Okay. Yes, flip over. Can you actually go onto your stomach? And then we can do femoral traction. So with this, you're flexing their knee and bringing it up, and if they have any pain or radicular symptoms, it could indicate a nerve problem. And then also palpating the sciatic nerve. For any sciatic nerve pain, you would have some radicular symptoms down the leg. And then finally, you can roll onto your back again. You can also do SI compression and distraction. So put your legs down, you would cross your arms and compress at the ASIS. And then if they have pain, you would distract it by pulling it up. And then Faber also can, put this leg down, can indicate SI distraction or SI pain by compressing here, but it can also indicate tight muscles in the IT band, the hip flexors, and then finally Thomas and Kendall. So it comes up edge of the table, grab your knee, and then roll back. And looking at, you can see if their leg is parallel or touching the table. If they're up like this, it could indicate hip flexor tightness. If you take out the quads and it's still up, then it would definitely indicate hip flexor tightness. But if it goes down when you bring the quads or extend the knee for the quads, it would indicate quad tightness. So also looking at the quads, seeing if their leg is down perpendicular to the floor. If not, if it's out like this, extended, it would indicate tight quads. And then seeing if their foot is rotated externally could indicate IT band tightness. And that's it.